Let's see, a little bit about me. I'm a registered nurse by trade, and I am a senior policy advisor at the FDA, and I've been doing that for quite a few years now. I have been with the FDA almost 25 years. I'm very excited about that, but I've been doing a few different things throughout the years there, so I've learned quite a lot. Right now with the area of policy advising, though, there's a lot to discuss. I'm going to focus on just a couple of areas, though, in the interest of time. So what I'm going to talk about mostly is the final guidance for home use devices, and this is something that I have been going on and on about for many, many years, and I'm happy to say it is now final. I will talk a little bit about the final guidance for mobile medical applications, but I have a feeling a lot more people in this room know more about it than I do. I will speak with conviction about it, but I expect you to correct me if I'm wrong. And then I'm going to offer a couple of research recommendations for further policy. First, I do want to tell you a little bit about these two people that I know, and their names are Harold and Dorothy. And Harold is 92 years old, and Dorothy's 80 years old. They live in Minnesota. They are absolutely adorable. They live in a 100-year-old house. They've been there for 52 years. They are going to leave that house in a box, as she says. They will not leave there, and they happen to be my parents. And I am very fortunate to have them both alive. I know how fortunate I am, and have them still together, and have them relatively healthy. They have a few functional issues, but I do believe Medicare does owe them some money because they have not used Medicare much at all. My dad now has a long-term catheter for his prostate. Other than that, they don't have anything else going on. I'm also very fortunate. It is a small community, so I was very happy to hear about that small community effort because people look out for them. And they're very involved in the community, and they have their card club, they have their cribbage club, they go to church, they deliver Meals on Wheels to the old people, and they also go and play bingo with the old people in the nursing home. And I asked my dad, I said, where are you in this scheme? And he says, what do you mean? So I find it to be a very fortunate thing that my mom can still drive, they get them around. And my father was just nominated for the Senior Citizen Volunteer of the Year Award for the state of Minnesota. So we went home for that, too, to celebrate with him. Now, with this home use final guidance, this is one of the first times that FDA has put the user into guidance. We typically focus on design of devices and the way they should be following certain standards and things. So I am proud to say we have the user involved in this, and I'll tell you a little bit more about that. Okay, and we're not looking only at the aging population here. We're looking at the people who have chronic illnesses that are living with technology in the home, and we're also looking at people who are going home for temporary use of technology in the home. This home use final guidance does provide certain definitions, and I find definitions are extremely important. The only one I'm going to read to you right now is the home use device because it is very broad, and it is a medical device that is labeled for use in any environment outside of a professional healthcare facility. This includes, but is not limited to, outdoor environments, office environments, schools, vehicles, emergency shelters, and independent living retirement homes. If the device is intended to be used both in a healthcare professional facility and outside of the home, it is still considered a home use device. We want to make sure that people are living in a healthy way and that they're using that technology to live in a healthy way, that they are not confined to their homes, but that they can live. They can go to the grocery store, they can go on vacation, they can go to the beach, they can do whatever they would normally do. They just happen to be carrying technology with them. There are three main points to this home use final guidance, and it is the design of the device, the user, and the environment in which it's going to be used. These are integral to each other. You cannot have one without the other. I will also talk about some other little pieces of this guidance that are just as instrumental, but these three are integral to having a good device that's going home with the user. So you're going to look at design considerations. We have to take risk management into consideration here. And I should mention that guidance is something that we suggest industry do. It is not a regulation or a rule. It is not something they have to do. But we strongly recommend that they follow this guidance. We also look at software. We talk about lockout mechanisms and how important they might be in the home. They may not be in the home. A lot of people don't like lockout mechanisms. If they have to have them, then they should have them at a minimum way, and usually just for the healthcare professional to come in and intervene. There are maintenance issues. As more and more people become owners of their equipment, they need to learn how to maintain their equipment. They need to learn how to clean it, calibrate it, store it all properly. And then the next one is calibration. We don't like calibration, but if you have to have it, then please make it minimal and make it step-by-step calibration so that it's not difficult to calibrate that piece of equipment. And then there are mechanical issues. How portable is that piece of equipment? How durable is it? We all know we drop our smartphones, we drop all sorts of things. So can they drop these things or bam them into the wall and they're still going to operate okay? One of the big issues here are electrical issues when it comes to the design of a device. And you have to think about when you are in that nice controlled environment of a professional healthcare facility, usually you're going to use the three-pronged outlet. But a lot of homes have those two-pronged outlets. And what does that mean when you are taking technology into the home? Is that device going to work okay? Can you operate everything else in the home with the electrical grounding that's there? Or what do you have to take into consideration? So this is what we ask manufacturers to look at as they're designing their device. The second piece that's integral to this is the user. And here you have the user, you have the physical, the size, the mobility, dexterity, strength, stamina. You have a 75-year-old lady taking care of her 80-year-old husband, and she has to get him in a patient lift, up out of the bed, move him over to the chair safely. And she's probably a lot less in weight than what he is, but you have to make sure that this can be designed as such that she can safely do this with her size and her stamina. We have the areas of sensory and perceptual. The industry needs to take into consideration that there are going to be vision problems, hearing problems, possibly tactile problems. There's the area of cognitive. And this is where most people make the mistake of thinking of home use devices. They think of them as being over the counter and having to have instructions for use that are easy to follow. That's one tiny, tiny part of it. There's literacy, there's comprehension, there's learning. How can you follow those instructions for use? How can you reference those instructions for use? So there are a lot of issues involved here. And finally, we were able to get an emotional. A lot of people don't understand that you're dealing as a caregiver or a care recipient or a care partner with a new diagnosis of either yourself or a loved one. There's treatment issues that are brand new to you. There's a device that's brand new to you. And your learning goes down significantly when you are having to take that piece of equipment home. And you get that one shot at teaching somebody how to use that piece of equipment. So design it with that user in mind. And then finally, the third piece that's very integral to this are the environmental considerations. Where is that device going to be used? Now, you can't cover all of the ground, but if you know that it's going to be a portable device and they're probably going to go on vacation, then design it as such that it can be portable and that they can go on vacation with that. This is one of my favorites, is contaminants, and people laugh at that, but there are a lot of critters in the home. There's dander, there's cockroaches, there are squirrels that eat through tubing. And you have to think about all of those different things. I know I dug out a lot of cockroaches from equipment when I was in that environment. But we do have things like pets sitting on laps while you're having peritoneal dialysis therapy, and that fur gets into the tubing. So you do have to think about the ingress and egress of things going in and out of that device. Water supply. Water supply is important because if you have water for your particular product, what kind of water can be used? Does it have to be distilled? Can it be chlorinated? Do you need reverse osmosis? What type of water makes that device function correctly? Temperature changes. If somebody is living independently with their device, they're probably going in and out of warm, like this room, to very cool environments. And you could have a problem with condensation. So can your device continue to function with extreme temperature changes? Dampness and humidity. If it's too dry in the room, is there going to be a problem when you're operating your electrical equipment and there's static? So this is something that the manufacturer has to consider when they're designing their device. Atmospheric pressure changes is mostly going to be low pressure environments if you're going into a plane or going up in the mountains. Airflow, can that device sit against the wall? Is there room for it to sit against the wall or room for it to move out? Because if it sits against the wall, are you going to have problems with overheating? So consider that. Again, travel, that's very important. And do you need converters, adapters? What do you need for that device if you're traveling internationally? Fluid exposure, can it be submerged? Can it be exposed to a certain amount of water? Can you take a shower with it? And what happens if you do and something fails? And then finally, storage. Can it be stored in the sun? Can it be stored in a dark room? Can it be stored where the pets have their litter box? You know, there's all those considerations. So you have the design, you have the user, and you have the environment. The other sections that we have in this final guidance are human factors plays into all of that. Usability, again, useful and usable. And if you don't have human factors from the beginning when you're designing your device, you are very remiss because it's the human that's going to be using that device or not using it because it's not usable. User training. And if you have to be trained in that, make sure that you have good training. Some of these devices even need certification, like home hemodialysis. The care recipient and the care partner have to be trained and certified in the use for hemodialysis. Labeling. Make sure it's good labeling. Make sure people can read that labeling. Make sure people can find what is in that labeling. So if they do need to find information, that they can find it. Handling the device in an emergency. And if you need to be operating that device in an emergency, what do you need to do? And this is where our medical countermeasures that Aaron was talking about yesterday, they're working a lot on handling devices in an emergency situation. Proper disposal, and this is state by state. There's something different for proper disposal of biomedical waste. Again, the hygienic maintenance, keeping it clean, disinfecting it, or sterilizing it. With what? And is that available? Is it readily available in the home environment for the user? There's post-market considerations. What do you do when you have a problem with that? How do you troubleshoot that? And who do you notify when you do have a problem? And I know something that I missed here were alarms. And when you are in a home environment, and if you have somebody, let's say, that is on ventilator therapy and they're laying in bed, you're going to be going out to do the dishes, you're going to be going out to do some gardening, you're not going to be sitting in there waiting for that alarm to go off. So we have requested that manufacturers have two different types of alarms on their home use device, whether it's tactile and auditory, whether it's visual and auditory, or visual and tactile, but that they have two different types of ways for people to know that an alarm is going off with that device. So that's our home use, and then I'm going to talk, again, with conviction, but probably not a lot of knowledge, about the mobile medical applications. So if I am incorrect, please feel free to wave your hand frantically at me. So there are two categories of medical device, of mobile applications. You're either a device or you are not. If you are considered a mobile medical app. They have intended uses. If you are a mobile medical app, you are either an accessory to a medical device, or you are transforming that platform, that smartphone, that iPad, into a regulated medical device. If you connect to a medical device that is regulated, exercising the regulatory oversight, you are going to be regulated if you are connecting to a medical device that might control that device. If you do specific things like storing or analyzing or transmitting that data, you will be regulated. If you are transforming that mobile platform, again, into a regulated medical device, you will be regulated. And if you're providing specific diagnosis or treatment options, you will be regulated. So it's kind of there, but there are a lot of different types of applications out there that people still kind of question, and we'll just have to answer them as we go along and learn about these things. There are areas when we've decided, well, we can't regulate everything out there, but they are technically a medical device and we should be regulating them. So what can we do? Well, we can exercise something we call discretionary enforcement. And we can decide that if something's going really, really wrong with that particular thing that seems to be pretty innocuous most of the time, we can tell you that now we are going to regulate you a little bit more toughly. So that's if you're providing supplemental clinical care. We'll kind of watch, see what's going on, but if it gets a little bit out of hand, FDA will step in a little bit more. If you're providing patients anything where they can track and organize their data, it's a nice thing that you can have that, and we don't want to have to regulate that too tightly, but we recognize that we can. If we're helping patients document and communicate that information to their healthcare provider, we'll be watching that, but it won't be something that we'll strictly enforce at this point. If you're performing calculations in clinical practice, another thing that we will exercise that enforcement discretion. And then having people enact with that's not really a HER, that's an electronic health record or a personal health record. So if somebody's interacting with that and we find that there might be something going a little bit amiss, we can also ask you at that time to come in and talk with us. So I had a couple of research recommendations, but then after I was talking with Erin yesterday, I thought of a couple more. The readmission rates of people with technology. These people are going home with technology. What kind of information are they getting? We do tend to look at drugs a lot and seeing how people are getting readmitted with drugs and therapy with drugs, but we're not looking at technology. So when they're going home with this technology, how do we know that they're operating this correctly to monitor and to take care of themselves? So I'd like to know what the readmission rate would be, people who are using technology. Possibly with a purchasing equipment after a period of reimbursement, when it becomes their own device, what's going on? Are they still able to maintain themselves in their homes after they have purchased that equipment and now they are responsible for that equipment? And another two that I thought of this morning was, how can we take a smart app for a known condition and see the effectiveness of the app? Is there some way we can monitor the effectiveness of that app? And then also we had talked yesterday about post-market studies of people in the home with technology and what types of post-market studies can we be doing to look at better effectiveness of use of this technology. And that's it. Thank you very much.
So, hello all. My name is Sherry Ling. First, a little bit about me. I am a geriatrician by training and also rheumatologist and internist, still practicing, volunteering at the Veterans Administration Hospital in Baltimore. I also serve as the Deputy Chief Medical Officer for the Centers for Medicare and Medicaid Services. Those of you who have worked with CMS understand that it is a very complex agency with that is charged with implementation of regulations and laws as they are described, and as such, the policies that roll out have to be true to enable implementation as the laws are intended. And as such, there may be a separate authority that reigns over quality reporting of home health agencies, and that would be separate and distinct from what the requirements are for conditions of participation in Medicare. So we acknowledge, it's not easy to find information or the answers that you seek that are relevant to a population of patients that is attempting to remain at home and to live at home. I also sit in the Center of Clinical Standards and Quality, which in and of itself is a bit diverse, but most applicable to your interests are where our coverage and analysis group lives. National coverage determinations and decisions and evaluations are conducted in our CCSQ. Dr. Susan Miller actually will be providing probably the most applicable information to you about how coverage, information on how coverage determinations are made, at least to information so that you can better understand the context for the need for evidence. We also, though, are charged with quality reporting programs across every care setting. Most notable in the hospital setting, and readmission rates certainly is something that the agency and the department are very interested and mindful of, because readmission rates, especially within 30 days, speak to further disability that perhaps could be avoided, and avoiding events of harm carry a very expensive price tag for both us as a country, but particularly for the patients who endure those readmissions. We are moving more and more towards a systemness of care. And I thought I would just frame some of my comments with the purpose of, or objective that is stated for this specific session, which is that we seek to understand the factors that allow people to remain in their private homes or communities, and to pause on that for a moment, because there is an important distinction to be made. What is within the patient's desired goals of care, and also the convergence with what is feasible. And what you're interested in is how to converge those two interests to permit remaining at home as functionally capable as possible. We also seek to understand how to improve outcomes and cost savings. That's a notable and important concept. So what outcomes matter, and what outcomes are meaningful? This is a thread that is woven throughout the policies that you will see for coverage determinations, for quality reporting, for our readmission reduction policies. It's about the outcomes that are most relevant to persons who receive health care. And of course, cost is another leg of the three-part aim. And then in all demographic populations, for people with disabilities and for people who are aging, we're actually seeking to knit together a mechanism or vehicle so we can understand or even document what their levels of function are. And that has been challenging because of the separate authorities in which measurement occurs. CMS remains the largest purchaser of health care, and representing a population, 1 in 3 Americans receive services that are somehow touched by or paid for by Medicare, including Medicaid and the growing number of health plans and exchanges. But this population aging in place. We as a country are aging in place. It's becoming even more complex. The number of multiple chronic conditions is rising. The number of persons who have cognitive impairment and dementia also are rising. And so CMS is part of the HHS effort to address those two populations, which I think are very relevant to focus on. So the question then also becomes, what are the meaningful outcomes to pursue in research, in finding technical solutions for, and also then that we can pay for and purchase through our authorities as an implementation and purchasing agency. The policies are built upon evidence that you all generate. Importantly, again, the question is, what outcomes should be integrated into those feasibility trials, into your evidence production and development studies? What outcomes can we converge on that are meaningful to patients, are measurable in the context of research and evidence development, and also that we can base policy decisions upon? So outcomes matter tremendously. And this is just a high-level overview of all the different policy levers that CMS has the authority to implement, of which coverage is a significant part. And we'll hear more from Dr. Miller in a second. But outcomes also are an important landscape that focal point in the landscape that we are driving towards in value-based purchasing. So we have 3 value-based purchasing programs thus far. We have the hospital value-based purchasing program. We have ESRD facilities called the Quality Improvement Program, and we also have the physician value modifier. These are based on the ability to measure quality of care and cost, and putting quality and cost together on the same page. And so that is an important thread, and over time, VBP will further focus in a very robust fashion on outcomes. So again, what outcomes should we be measuring? And these would include patient-reported outcomes. The challenge here is, what is our data source for patient-reported outcomes? We have legacy instruments that provide us with data sources in home health, but those are reported by the agency personnel, which ideally reflect the patient's outcomes and observations, but it is not the same as a patient-reported outcome. So there are efforts underway to be able to integrate that data source over time. And I think Susan is going to cover this in a little bit, but again, why outcomes matter so much is that this is a guideline for coverage determinations in the Medicare beneficiary population, where therapeutics are expected to deliver clinically meaningful improvement in outcomes, and diagnostic tests of which would also be utilized to make therapeutic decisions that translate into improved outcomes. I will spend a moment on the Innovation Center because what I've talked about thus far is under the traditional Medicare construct, the traditional construct being fee-for-service. That landscape is changing with many demonstration projects underway, and much of that work occurs within the CMS Innovation Center, or CMS Medicare and Medicaid Innovation Center, CMMI, and there's a distinct and separate website for CMMI that I urge you to look at, because it is a display of not just its unique authority, which is separate from the authorities granted to Medicare, traditional Medicare through fee-for-service, but the Innovation Center is tasked to test innovative payment and service delivery models to reduce program expenditures while preserving or enhancing the quality of care to beneficiaries. And this authority came through the Affordable Care Act, and represents, importantly, a historic shift from the state where it is fee-for-service, volume-driven, producer-centered, and very fragmented. If you think about you're trying to age in place in your home, you have to go to a physician's office, you go to the hospital, you go to a post-acute care setting, you may need to receive services at the dialysis facility. They are all independent and are likely to rely on you as the patient or your family for the information. What happened to, where were you? You know, I was in dialysis, I was in the hospital. That information needs to be shareable, and there are technical solutions, including health information technology and electronic health records, an important part of the solution, but still those are tools. So we're moving both in the private and public sector in parallel towards a state where is more person-centered and driven by outcomes and care that is well coordinated over time, longitudinally, as well as across all care settings. And the payment system and other policies currently underway include value-based purchasing, accountable care organizations and communities, state innovation models, all of which are testing feasibility of maintaining or improving quality and reducing or maintaining costs, but certainly not to increase costs and lower quality. So this is all within the Innovation Center charge, and we are at the verge of a very exciting transformation that will also call attention to how physicians can and the healthcare community can contribute to, again, meaningful outcomes. What are the outcomes that are desired for patients and families? This is just a high-level summary of some of the Innovation Center's portfolio. This has been, will be updated on a regular basis, again, on the CMMI website. We've enjoyed initiating the Healthcare Innovations Awards. Probably many of you are recipients of that. Still, data will be forthcoming based on the evaluations that would be conducted in year 3, after year 3. But also Healthcare Innovations Awards Round 2, which has recently been named and importantly called out the need for care delivery models and payment models that address a vulnerable population of patients, which is the patients who with multimorbidity, behavioral health issues, at risk of harm and rehospitalizations, including those with multiple chronic conditions and dementia. So just returning to the original charge of this, I think we have a tremendous opportunity to really converge and accomplish what is stated here as a challenge, but in doing so, we do need to converge on what those outcomes that can be included and should be included in studies that you all contribute to. Importantly, those outcomes must be relevant to the Medicare population for coverage to be considered for Medicare. I mean, you know, that does make sense. But also importantly, picking up on a thread of something Mary mentioned, you know, the data have to be true to real life. So it is fine to have data demonstrating stellar test characteristics in vitro or in a laboratory setting, but to be able to use it to improve function, to maintain function, to achieve outcomes that are desired in the home, optimally there will be data that comes from the home and in real life. So I will stop there and I will turn over to Dr. Susan Miller from our coverage group.
Good morning. I have no slides, so that's fine. Well, let me introduce myself. I am a board-certified physiatrist. I practiced for 20 years before coming to CMS, where I am a medical officer in the coverage and analysis group, and I have been there for almost 7 years. So what I want to do today is to give you a very high-level view of the principles that govern coverage for Medicare, because clearly if there are devices, et cetera, that need to, that can promote health care and in the home, you all need to know if it's realistic for Medicare to cover those devices or not. So let me start with the fact that, which Sherry alluded to, we are governed by the laws, rules, et cetera, that Congress gives us, and we really cannot go out of those laws. So you need to know that Medicare pays for items and services which are reasonable and necessary for the diagnosis and treatment of illness or improving the functioning of a malformed body part. That's it. That's our authority. In addition to that, Medicare has given us a list of benefit categories for which we may pay. So in other words, in order to pay for an item or service, it must fit under a benefit category. A benefit category allowed by Congress is obviously things like physician services and inpatient hospital services, but as you all know, it's diagnostic tests, durable medical equipment, prosthetic devices, and all of these benefits have definitions which we must adhere to. Now, you think about sensors in the home connected to an appropriate device, whatever. And so you have to wonder, what benefit category do these devices fall into? And are they monitoring devices? And if so, are they preventative devices? Medicare is only allowed to pay for those preventative services that are either statutorily allowed by Congress, or because of the Affordable Care Act, those items or services that receive A or B recommendations from the United States Preventative Services Task Force. That's, again, that is it. That is all that we are allowed to pay for. So when we were talking about what was going to happen in my talk, I know some of the conversation was around the fact that no matter how good the research is, Medicare has turned down whatever it is that I feel is reasonable for a patient to have in order to age in the home. And part of that reason may be the fact that there is no benefit category. And if you remember nothing else from what I say, please remember that. Now, in addition to the fact that you need a benefit category, you also, in order for a device to be covered by Medicare, it must be approved or cleared by the FDA, thank you, Mary, for at least one indication. Now, there are some items that can be covered outside of that, but I think that for the purposes of this discussion, it's important to know that. So you must be FDA cleared or approved. But, and here's the big but, FDA approval or clearance does not guarantee that Medicare will cover any item or service. One, again, and I'm going to say this a number of times, there must be a benefit category. But two, CMS has a much different legislative authority than does the FDA. The FDA, in a nutshell, and I'm simplifying it tremendously, is looking at safety and effectiveness for the given label. Again, Medicare is looking at whether or not the item or service is reasonable and necessary for the diagnosis or treatment of an illness or injury or the improvement in function in a malformed body part. And really, those are two different things. It is quite possible for a device, for example, to be approved by the FDA on perhaps people who are 25 to 45. Okay, so it did get clearance. It did what it said it did. It's effective. It's, it's safe, et cetera. But we are interested in our population. If it was perhaps researched on a population of 25 to 45-year-old persons who are disabled and therefore have Medicare, that's terrific. But if it's to be used in the world of those who are 65 and older, we have to do a coverage. We have to at least look at it very carefully, and in some cases, we have to do either a national or local coverage determination. So what is it that we are looking for? We are looking for evidence that is generalizable to the Medicare population, whichever population, whether it's our disabled population or our over 65 population or both. We are looking for evidence of sufficient quality to determine that, one, the item or service falls into a benefit category and that it is reasonable and necessary. So what we ask ourselves is, how confident are we, or is there sufficient evidence that the device does what it's supposed to do and that the intervention will improve the net health outcomes of our beneficiary population? So that means we're looking at, one, is there validity to the research that shows a causal relationship between the intervention and the outcome. Number two, what is the impact of that outcome? Let me give you, I mean, the validity, I think you all as researchers can, you know, you can recognize. But what is the impact? So let's say that there is a device that helps you to walk faster. So the question that we will ask is, what is walking faster associated with on the positive side and on the negative side? I mean, obviously walking faster can cause falls, et cetera, but what is it that it gets the patient to do? Okay, are they able to remain in their house? Are they able to, you know, by walking faster, are they able to, somehow are their ADLs increased? That sort of thing. All right, so you have to be very careful about surrogate outcome measures versus functional outcome measures, because we want to see what is important to the patient. We've also looked at studies that show physiologic changes, all right? So for example, if you do a brain scan, this part of your brain lights up or that part of your brain lights up, and therefore you make a conclusion. But that is not important to the patient. What is important to the patient is what they are now able to do because of that change. So those are the kinds of outcomes that we are looking for. Obviously, we are looking for the risk versus benefit profile. We know that the FDA has looked at that too, but we are looking specifically in our population base. And finally, we want to make certain that this is generalizable to the Medicare population. Okay, is it for our older patients? Is it for our younger patients? Is it only able to be used in a university center? Okay, or can it be extended out to community docs, that sort of thing. So those are the basic points that I want to make about coverage. I have for you these sheets, which I'm going to leave up here. There is some literature about what we consider at a national level. There is some literature about what is considered at a local level. And also there is a link to something called the Innovator's Guide to Navigating CMS. If you have not read that yet, I really urge you to do that. I have talked about coding. There is also, I have talked about coverage. There is also the concern of coding and payment. People get coverage, okay, but very often they get a code before they come to us for coverage, and they assume that getting a code gives them coverage. Please, that is not true. We can talk about that a little bit more in the question and answer session if you want to, but coding does not equal coverage. And then finally, coverage does not equal the payment that you necessarily want. These are three different processes, and again, I commend to you the Innovator's Guide for Navigating Medicare. It has a lot of links into inpatient payment, outpatient payment, you know, all that DME payment, all that sort of stuff. So finally, let me just, again, sort of drill down. You need a benefit category, and then you need coverage. In order to get coverage, you have to be looking at an appropriate outcome, as Dr. Ling said. We are happy to speak with anybody about what the outcome measures are that we are looking for in terms of your device. We do that informally for all sorts of investigators, manufacturers, distributors, et cetera, because we don't want you to do a lot of research and at the end come out with something that is potentially not helpful to us and certainly not helpful to how we evaluate things for our patients. So during the question and answer session, I'd be happy to drill down into more information about this as you all need. Thank you.
Okay, good afternoon. I'm Melinda Benton, and I am honored to be here and it's a privilege to be speaking last of all the panelists because so many panelists going before me have said some of the things that I've said, so I just have to reinforce them. I do bring to this discussion a variety of perspectives. I started my career at the RAIN Corporation, where one of my major projects was the design, implementation, and evaluation of the inpatient rehabilitation facility prospective payment system. And that's where I got first acquainted with issues in disability and rehabilitation. I then worked as the chief economist at the Office of the National Coordinator for Health IT during the initial rollout of the HITECH Act and the incentives for electronic health records and all of the hope and passion that went into that effort to try and digitize healthcare records. I then worked at the Congressional Budget Office, which, as Susan didn't have to tell you, but if you're looking for a device or some other device or something like that to be included that doesn't fit all the criteria that she's talking about and requires legislation, one of the first stops that piece of legislation will take is the Congressional Budget Office, where the analysts there will be asked to look at the fiscal and budgetary implications of covering that device. And in today's fiscal climate, that usually means that if the device is associated with, or protocol or things like this are associated with significant additional costs, their chance of that legislation passing is severely diminished. Now that I'm at Vanderbilt Medical School, in the past year, I also sat on a working group, an advisory group to the President's Council of Advisors on Science and Technology. And in particular, we worked on this report here. My slides will be online, so you'll be able to find the URL. And this group looked at the application of systems engineering principles to healthcare systems and ways in which they might improve the value that we're getting out of the healthcare system. It really is the type of companion report to the IOM report on learning healthcare systems and other things that you may be aware of. But it looks particularly in the federal context and makes a number of different recommendations for agencies, federal agencies to follow that would be in pursuit of the goals of a learning healthcare system. So this is a perspective that I bring to the discussion, and I'll just pull together things that you've heard from a lot of my colleagues, in particular my colleagues who are still in the federal government, like Dr. Eads and the people on the panel. And I will quickly summarize what my key takeaways are. The first one is that if you think the current state of the world is difficult, the projections that my colleagues and I did when I was at CBO show how difficult they will be in the future. And I'll show you a few charts, very similar to the ones that you saw Tom and Marie yesterday present, but just to hone in a little bit more on the issue of aging and where people are going to be aging. The second plea I would make to you is to consider how a technology might be paid for. So Sherry and Susan have told you very explicitly the Medicare rules, but consider how technology might be paid for in the current environment and consider what it might substitute for. Because as Sherry was telling you, we're now starting to approach the world where organizations will take responsibility for delivering care to beneficiaries and can, in essence, set their own coverage decisions within the Medicare benefit package in the way that achieves the best value. So, for example, Beth yesterday mentioned accountable care and the move towards accountable care. Now, I'll show you one slide that will indicate that we're still a ways off from that. But if we're talking about a future state of the world, that's one in what you should be thinking about. And then my final takeaway would be, just as you're planning to collect data on efficacy and how you might design your products better and whether they work, think about collecting data in phase 2 or phase 3, if you will, of your trial to support a value proposition. And I'll give you one example of a mobile telehealth device that did partner with a health economist, one of my colleagues, and where there is some good evidence of cost savings. Okay, so that's where I'm going quickly, and I'll move through it fast. So first, you've seen a lot of slides that look like this. This is just one that I happened to put together with my colleagues at CBO. The URL, again, here is at the bottom if you ever want to use this chart. And what, in essence, it shows is that right now we are here in 2010. And we're at about 13%, right close to 2010, obviously. We're about 13% of the population is over age 65, and by 2030, we're going to be at about 20%. And obviously, the share that's in the oldest age categories is going to grow further past, I guess this is 2032, when baby boomers start turning age 85, right? So this is the 75 million strong baby boom cohort. All right, and this has implications for the federal budget. Again, this was my perspective when I was at CBO. This chart shows you the billions of dollars that Medicare spends for post-acute care. And as anyone in this field knows, the line between post-acute and long-term care is not black and white. It is a very gray area between those two things. So Medicare has increasingly paid for community-based care, as you can see on this chart, but also pays for institutional care, like skilled nursing facility care. This has been growing over this period at about roughly 6%, and the total is expected by CBO to grow a little faster than that due to the aging of the population. And then on the Medicaid side, of course, the Medicaid is paying for a lot of institutional nursing home care and a smaller amount of community-based care. And it is expected to grow even faster. This slope of this line is about 8% per year over the projection period. At the same time, due to the changing composition of the population and due to changes in women in the workplace, other trends, increasing disability among the working age population, we're going to be straining the caregivers available. And that's something that all of you in the room should think about as well. What this chart shows, again, CBO projection from 2010, about 5% of the non-elderly population involved in caregiving, to by 2050, about 10%. And we have different scenarios here about how that would be affected by how healthy these elder cohorts stay. But you can see it's still projected to be a significant demographic change. Okay, so where are we? We're currently in this big mishmash of how we pay for care. So I've asked you to think as you're developing these technologies about how they'll be paid for, but there's a lot of payers operating in this arena, if you will. You've heard about Medicare. Okay, but Medicaid really is a large payer in this arena in that they are the long-term care insurance policy for which the deductible is virtually everything you have. And a large proportion of our population do fall into that category because institutional nursing home will drain their resources, or if they are trying to remain at home, home care that is not covered by Medicare can quickly drain their resources. Okay, so Medicaid is the insurer of last resort. Long-term care insurance is currently held by fewer than 10 million people. Again, people in the room are disproportionately federal workers who have access to pretty good group policies for long-term care. It has not experienced big take-up across the country. And long-term care insurance, I actually was looking this up to see what does long-term care insurance coverage cover in terms of in-home devices and things like that, and it's very unclear. So that's a possible area for research. There's some state-based hybrid insurance policies I won't talk about. Some people are putting money away in health savings accounts, but obviously they can be exhausted, and reverse mortgages is probably something that is going to receive more attention in the future, again, just because we have this bubble in our aging cohort. When we think about home and community-based services versus institutionalization, a conclusion that a lot of people want to jump to right away is that home-based care is always better. And if home-based care is, and not only that, but that home-based care should be cheaper than institutional care. And the fact is that most research in this area has shown that home and community-based service programs, unless they're extraordinarily well-targeted, will cost more than institutionalizing people who reach the point that they need that level of care. And that is unfortunate. It doesn't mean that institutional care will be better or in line with the preferences of older adults, but if you're looking at it from a purely fiscal point of view, that is the case. And indeed, there's this article here I mentioned, the March 2014 study, is showing that there are some drawbacks to community-based care in terms of things like rehospitalizations. And so the types of technologies that people in the room are developing may help to overcome some of these problems. But I would urge you to think, just as Dr. Eads urged you in the prior session, to think about how do you target these technologies to the people with the greatest use? Because if you don't, you probably will find that they won't fly in the current fiscal environment. Okay, I will skip over long-term care insurance because I've already made the main point that long-term care insurance policies, it's really unclear how they will cover assistive technologies, and that's probably an area where someone could do an interesting, sort of more legal-oriented research project. Okay. But if you're thinking, but wait, Sherry showed me that great slide, told me, Susan told me to look up the Guide to Innovators. Isn't the Center for Medicare and Medicaid Innovation going to change all of this, push responsibility to providers, come up with innovative risk-based care models? Well, possibly yes, but it's going to take a while to unfold. This chart shows some data from a study produced by one of my former students, Carrie Kalla at Dartmouth. The colored lines represent different types of accountable care organizations, but that's not the point I'm trying to make here. Notice here that this tops out at 50%. So these are accountable care organization executives reporting what they're going to be focusing on. And really the things that they say that they're going to be focusing on are fairly simple. So here's some of the biggest category. Fully develop a program to assess and reduce hospital readmissions. Okay, well, we all know that we are supposed to have been doing that for a few years ago. And if you want to do something sort of more complex, have a complex chronic care management in place. Well, if you look across all ACOs, it's barely 30 who even have sort of any capability in that area at all, and we probably wouldn't call it very sophisticated. Down here are some of the things we might think are more sophisticated, like medication management, reminders for preventive care. I mean, we are not talking about very sophisticated interventions here. And again, small numbers of ACOs reporting they're able to do that. So we have a long way to go to do the things we already know how to do in accountable care organizations, much less incorporate all of the data that you would like to supply them with. Okay, so how are we going to make progress? I think we are going to make progress if, as you develop wonderful new initiatives, interventions, technologies, you keep in mind, again, in that phase 2 or phase 3 of your research, to bring in the issue of the value proposition you're creating. So this is one example of a study that when I was reviewing this work at CBO, I thought was particularly well done. It was done by Lauren Baker, who is a health economist at Stanford, and it was of the Health Buddy product, which is a Bosch product. I don't actually believe that it's covered by CMS, but CMS did get involved in this particular research study and did help Bosch and this research group based at Stanford to randomize Medicare beneficiaries into an intervention and control group. Well, they didn't actually randomize. They chose a randomly selected group of control clinics where they could be compared to. And they looked here at average beneficiary spending per quarter. That was their outcome. And they concluded that the beneficiaries who were using the Health Buddy device did have lower spending. There's a big confidence interval on it, but it was about 7 to 13% lower spending per quarter than beneficiaries in the control group. Now, again, this is another thing where Susan would say, this doesn't mean that Medicare covers it now, but at least there's evidence that on an outcome that Medicare cares about, that a Medicare Advantage plan might care about, that a Medicare ACO might care about, there were some savings. And so that is one positive example. So I'll just sum up by restating what I think is the main question that I heard from my perspective as I pull together my thoughts coming out of this entire workshop. What I see as the challenge is, how do we create an environment? And an environment means a technology environment, a privacy and security environment, and a policy and reimbursement environment in which older adults can stay in their homes as long as they are reasonably capable of independent living with the assistance of technology. And this is a question that I'll take with me back to my research. So thank you all.